Hey everyone, this is Paulius. We're back at it with another great recording. This is episode 6 of Voices of Table Rounds, where we showcase creative ways to learn medicine. This episode features highlights from our live game on April 30th with Valeria, Kiara, Kannu, and Kirtan. Here you go.
Yeah, so as the Kannu mentioned and as the Kiara mentioned, that we know that lithium can cause renal failure, right? Lithium can cause nephrogenic diabetes insipidus. And once you go beyond certain limits, especially if you are simultaneously taking, let's say, some diuretics, then it can increase the serum levels of lithium and it can cause renal failure. And when we have renal failure, it is imperative that we will have buildup of blood urea nitrogen, so nitrogen substances, urea, so that can cause altered mental status, probably confusion, and if it's severe enough, then even uremic encephalopathy. And if I'm not wrong, that since lithium being a heavy metal, just like lead, arsenic, mercury, you can sometimes even rarely get lithium encephalopathy by itself, regardless of its effect on renal things. So we have two-pronged effect: renal failure causing encephalopathy and lithium itself causing encephalopathy. And that's why I guess what you mentioned is very important, and maintaining level between 0.6 and 1.2 so that we don't tamper with the therapeutic index.
Yes, okay, so I'm gonna choose PPIs and hemoglobin. So proton pump inhibitors can cause iron deficiency anemia, and usually it is because you need acids to convert the iron from +3 to +2 and be absorbed by the enterocytes. And a cool fact that I found recently, actually, when seeing a patient, the case of a patient that had hematuria in the emergency room, but actually it was bituria, and the patient had iron deficiency anemia. And bituria is a cool way that you can diagnose iron deficiency anemia, because the same thing happens when you don't have iron, and the thing is, like, the acid levels on the stomach change because your stomach starts kind of excreting more acid to absorb more iron that is missing. And so the beets kind of have a component that when it is acidic, it is more absorbed and also passes through the blood and to the kidneys, and you have bituria. And so the patient didn't have hematuria but had iron deficiency anemia, and that was the way that we diagnosed it.
All right. So I think my connection would be a very simple one. I would like to add heparin to the CBC. I can think of two connections here with the CBC. I think the first and the most obvious one would be that excessive heparin use can cause bleeding, which may present with anemia and therefore a decrease in hemoglobin levels. The other thing when I think of heparin and CBC would be a decreased platelet count with the use of heparin, which is heparin-induced thrombocytopenia. It can be of two types. The type 1 is non-immune mediated and the type 2 is immune mediated. The type 1 is very commonly present, and it usually happens in 1 to 4 days of giving heparin. And it usually resolves on its own with heparin discontinuation, while the type 2 is the more serious one, for which we use a 4T score to diagnose it. The platelet count, I think, usually do not drop less than 30,000. And we usually use algatroban or any other anticoagulant in place of heparin to resolve that situation. So another thing, like I would like to connect it to the two previous things that I've mentioned. Like heparin bleed can probably lead to an intracranial bleed that can present with an acutely altered mental status, which may require like urgent surgical evacuation with infusion of PCCs. And the other thing is heparin-induced thrombocytopenia actually can have thrombotic complications as well, and it may actually cause an ischemic stroke in the brain, which can also later present with an altered mental status. I think the other thing would be like cerebral venous thrombosis or something like that, for which we can give anticoagulants like heparin. I think those would be the major connections that come off my head.
Okay, so when we talk about the causes of angina, as the Kiara mentioned, that gastroesophageal reflux disease is one of those things which you have to keep in mind. And when we talk about some rare things, let's say if someone has got, episodic angina, every once in a while, the patient gets, headaches, patient gets like night sweat, something kind of that. Patient can get even abdominal pain. because we know that when the levels of catecholamines go up in the blood, it can cause constriction throughout the system. So, I mean, I have even read about cases where the patient can present as acute abdomen kind of situation, extreme abdominal pain, like 10 out of 10 out of severity. And it's due to the mesenteric ischemia actually, because the celiac vessels, superior mesenteric vessels are constricted due to the high levels of catecholamines in the blood. And the same thing can even happen to the coronary vasculature. So pheochromocytoma can definitely cause acute myocardial infarction. That's the thing which we always fear about. And it can even, kind of present as a warning sign that you can get angina, and later on then you can get full blown infarction. So anyone present with recurrent angina and you don't have the classic risk factors like hypertension, diabetes, then endocrinopathies, including pheochromocytoma, is something that we should dig deep into, and maybe it can reveal answers.
Okay, so I'm gonna choose fungus, and I think fungus that can cause hemoptysis is Aspergillus, which is really great because, I mean, it has a lot of clinical presentations like aspergilloma. Usually it invades cavitation of a patient that already had TB in the past, or it can be an invasive aspergillosis, which is most commonly presented with hemoptysis, or acute bronchopulmonary aspergillosis, which can also present with bronchiectasis and hemoptysis. And yes, I think that's my connection.
In patients that undergo dialysis or post-dialysis, they can sometimes not sometimes, they can tend to have high levels of or tend to have uremia, and that can translate in, it's like vessels toxicity in especially coronary vessels, and this can produce angina.
Yeah. So does anyone, I have a couple of things I could add that I think when I think of those. So one thing I think is pericarditis, because you can have uremic pericarditis. I think it even goes with like uremic frost. I don't know if you've seen pictures of that where it's like a certain skin pattern. And with pericarditis, what I remember is that it is better if you lean, like the pain is better if you lean forward, and then when you lay supine, it gets worse. And that's one of the physical exam findings, in addition to the friction rub that you hear, colchicine as treatment for it.
As Kirtan mentioned about pheochromocytoma, so as you all know, Men's syndrome is definitely associated with pheochromocytoma in familial cases. And it's one of the things that if you operate for any tumor in any Men's syndrome, you always have to rule out pheochromocytoma before operating any patient, because otherwise they can land up in trouble. The other thing is PPI with men. So Men's syndrome usually have pancreatic tumors, which can also range to gastrinomas, which can cause Zollinger-Ellison syndrome. And we use PPIs to treat that before we try to surgically resect them. So those are pancreatic neuroendocrine tumors. And with heparin in men, I'm not too sure, but since pancreatic cancer is common in Men's syndrome, and they can have migratory thrombophlebitis. So I think if it's too severe, maybe we can use anticoagulation like heparin to treat it.
Okay, so now I have ALT there, and then PPI, hemoptysis, and uremia. So I have to link them. It's a tough job. So let's see what I can do. All right. So now when we think about the liver injury, and with the liver injury, you can get elevation of ALT and AST, right? And we know that one of the common cause of liver injury is the drug-induced liver injury, and literally any drug can injure liver. And certainly PPIs are not an exception. So every once in a while, you can get liver injury from the PPIs. And usually when you have drug-induced liver injury, then you can have fulminant liver injury. And there are lots of criteria for defining the fulminant liver injury. But one criteria that I remember is that it usually affects the synthetic function of the liver too. And when that happens, you have low albumin, as well as PT and INR and APDT will go up, because you will not be able to synthesize the coagulation factors. And that is what we know as coagulopathy of liver failure. And it is a very terrible condition wherein people can literally die in front of you. So that can lead to hemoptysis. And one of the important ways to differentiate the coagulopathy of liver failure from other causes like disseminated intravascular coagulation is that the levels of factor 8 will usually be up in the patient with coagulopathy of liver failure. Whereas in patients with DIC and all other causes of bleeding, the factor 8 levels usually go down. And the only reason is that because liver synthesizes all the factors except factor 8, because factor 8 is usually synthesized in the endothelium. So when you have got liver failure, then all levels of all other factors should go down. But factor 8 won't go down because it is synthesized by the endothelium and it is metabolized by the liver. So if you have got liver failure, you can't metabolize the factor 8. So actually factor 8 levels will go up despite having severe coagulopathy. So that's the one way to track the coagulopathy of liver failure. So that can cause hemoptysis. And when the liver failure is severe enough, we can get hepatorenal syndrome, right? And when you get hepatorenal syndrome, you can get uremia. And hepatorenal syndrome is also one of those conditions which you can, stabilize by giving like vasopressin or terlipressin, like midodrine, but you can't treat it unless you go for liver transplantation. And patient will suddenly go into kidney failure too. There is no way to treat it. So it's a terrible condition. So all in all, if you take PPI and if you end up getting liver injury, it's a very dangerous situation for you.
I don't know if you know this one because I actually learned it from Kushal, which is or Ravi, which is one of the members of CP Sellers. And so my connection is fungi, estrogen, and liver or liver enzymes. And I was thinking of paracoccydomycosis, which is a fungi that can actually manifest as splenomegaly, and it is more prevalent or 10 times prevalent more in men than in women, and it has been associated with lower or like a protective effect of estrogens.
So whenever I think of estrogen, I think of it like a steroid, and as Kirtan mentioned, anything can destroy the liver. So I think estrogen supplementation or like taking too much OCPs, as we know, can increase the liver adenoma, and it can also increase drug-induced liver injury. It's just one simple way to, I think, put at it. You cannot. Other thing I would say is like in cirrhosis, like the liver enzymes are raised, and you also have like an increased estrogen levels, which can cause various clinical features like gynecomastia, testicular atrophy, and loss of pubic hair, axillary hair, and even spider angioma, which are seen on the chest because the estrogen, which is there, it actually causes vasodilation, which actually manifests as those small central radiating arteries that we usually see in patient of liver failure. I think that would be like my connection. Yeah.
This was actually really fun. I mean, before joining you guys here, I was really scared because I was nervous, and it was actually a really safe space, and I learned a lot from all of you, and I will definitely do it again and recommend it to everyone because I feel like even if it was just virtual, it was really fulfilling.
Yeah, I mean, same as Valeria, I was scared that we will have like 10 people or 20 people watching us play. So that could put me into the spot. But I have all the friends here. So I'm even more excited to play with you. And I see that you are also very friendly. So it's very nice to learn from you too. And definitely you can share, pulse with us, like how to manage the patients in real life, because we actually read about the patients, whereas you as a resident deal with the patients, right? So you can teach us the practical pulse, which we can't get from books. And it's always amazing to learn from fellow friends who share their thinking. Definitely, I will do it again. Even if it's 3 o'clock in the night, I will do it again for sure.
I totally echo Valeria and Kirtan's points. Like it was a really fun exercise, and especially with friends, it becomes a really like a pleasant environment to learn new things with. But I think making those connections are also important in the real life when you are like taking care of patients, because sometimes it's just like it's like a light bulb, and it's like an idea that you never thought of. And I think it's a fun way to share those ideas.
Well, same as Valeria. At first, I was very shy and I was nervous because I know Kirtan, Kannu, Valeria are like big brains. But yeah, it is an amazing exercise, and I definitely do it again. And I will be thinking about like many ideas. Be creative.
Sure.
Thank you.
Thank you for
Thank
Yeah,
you.
too. We love
See
your
you.
company too.
Bye-bye. Thank you.
Bye. Take care.
Thank you for listening to the end. You did it. Reminder that none of the information discussed is medical advice, and everything we talked about is for educational purposes only. We look forward to our next episode. Stay tuned.